Okay, looks like we're good.
All right, good morning, LAFD. We had our August EMS centralized training as a bloody airway. Thank you all for participating in that and giving it your all. I'm here with Dr. Hammond today. He's going to talk a little bit about just some airway management techniques for a patient like the experience. So a lot of you guys did a great job, but Dr. Hammond just wanted to go over just a little bit more clinical knowledge behind on how we manage these bloody airways. Okay, he had an opportunity to talk with some of the guys. He dropped by for some of the trainings, and he was able to discuss some of the techniques. But we're going to record him today so we can share with the rest of the department. So, Dr. Hammond, about that, it's all yours.
Yeah, so I thought this was a great training exercise. We're going to definitely do more of these. So I appreciate you guys getting involved and giving us some feedback on it. So let's go back to our patient that we had fell off a third-story scaffolding and laying here, unresponsive, bloody face, bloody airway, and gurgling respirations. What Captain Pacheco kept saying, it's just gurgling respirations. So oftentimes when I come up to a patient, right, the first thing I ask them is their name, because their name tells me, one, are they able to speak and move air? So my airway is open, my breathing is adequate, and they're able to speak. And two, it's basically, are they mentating that they know their name? So often just when I come to the patient is hey, what's your name? And this man has gurgling respirations and he's bleeding out of his face. So everybody likes to use a lot of 4x4s. I hate 4x4s like we talked about because it covers up this airway when you pack 4x4s. So easiest thing is you want to be able to see the bleeding. So I can see the bleeding and I can control it just with direct pressure. Now, whether that's the paramedic or whether that's the EMT or whoever, to start with, you're just trying to control the hemorrhage. So direct pressure over wherever that's bleeding, you can just control that, okay? So if we say stop any kind of major hemorrhage to start with, we're then able to move on to the airway. So if you've got a lot of bleeding and someone's exsanguinating somewhere, you've got to control this hemorrhage before you control their airway. Otherwise, they die from that. So controlling hemorrhage first with just direct pressure to his face. And now you see he's got bloody airway and a bunch of facial trauma. Next step is, there's no right way algorithmic pathway to do this. This is all about kind of what your resources are. So currently it's Captain Pacheco and I, and there's nobody else on scene. I'm not going to do a lot with him other than probably try to get his airway and let's get us moving. Can you consider rolling the patient and getting the blood out of the airway while you get the suction? Absolutely. Number one concern when you have a patient who's fallen from any kind of height or any trauma is you've got to at least think about their cervical spine mobilization. Initially, that doesn't come from any kind of a C-collar, that comes from just your hands, right? The patient's unresponsive, he's not agitated, he's not moving. So your inline stabilization really just comes from probably holding his head and controlling his hemorrhage at the same time, but thinking cognitively about controlling that C-spinal mobilization. So once we control his hemorrhage, second thing is managing his airways. Best place to start is probably just suction. So start getting some of that out of there. He's unresponsive, probably doesn't have a gag reflex. So you're just going to suction to start with while you prepare the rest of your supplies. Three options, I think, when we talk about his airway. So we can do just an OPA with a bag valve mask. We can do a King airway, or we can intubate him. Intubation is probably the most difficult one, especially given the amount of blood here, facial trauma, potentially a face that's just collapsed in that doesn't support the pressure from a BVM. So let's start with one option. So you suction this. I'm going to hand this hemorrhage off to somebody else who's going to control this while I'm doing it. And then my first option that usually is the fastest to start with is just putting an OPA in, supporting some of that airway.
So given the times, guys, we're still recommending that you put that viral filter on there just for COVID and keeping that virus contained in the patient.
Absolutely. So OPA is in. He's going to be holding C-spine stabilization and controlling hemorrhage, so he's not really going to be able to help me create a good seal. So we got to try to work our way into here to get a good seal and bag, okay? And you'll see if you're able to, if you get enough relief, you got an extra hand and you can seal this better. But some difficulty just with the amount of trauma and bleeding to the face is going to be difficult to bag, but it's probably your first line therapy to be able to oxygenate and ventilate him. Certainly we're not using NPAs, right? So we see enough facial trauma, this is going to go right through their curviform plate and into their brain. We're going to avoid that for sure, okay? So OPA with this, we've got N-Tidal, we can hook all this stuff up, okay? Second step, I would say, and probably the one that seems most appropriate in this scenario, given just the complexity that his airway is going to present to try to do an ET tube, would just be a king airway. So let's say we control this hemorrhage, we've got him bagged a little bit, we're working, somebody else is getting monitors on him or an IV or whatever else anybody's doing. That's not your primary concern. Your primary concern is now, once you've controlled this, is to now move on to his airway. Everything else, if it's happening simultaneously, is fantastic, but you're, as the primary clinician on scene, this is your primary concern. So let's say we bag him a little bit, we start to get a monitor on him, we can take his OPA out. Then I use just the king airway. So the beauty of a king airway is, 99% of the time it's going to go into the esophagus, blow up this balloon, occlude the esophagus. This will then passively ventilate around between this balloon and flow into the airway. If you happen to get this into the trachea and you blow this tube up and you blow this tube up, this is not going to ventilate well. So you're going to have significant resistance when you're trying to bag. If you encounter that, this is where you deflate the balloons, you pull back out, aim a little bit more towards the right side, which is where the esophagus takes off from, where the trachea is a little more to the left. Aim it a little bit more towards the right. Let's do it again and see if you get better compliance. And with putting this in, you've got to maintain C-spine immobilization. So your other partner, whether it's they're holding that and holding their neck, pulling their jaw, we lost some of the bloody slipperiness of this. All right, then inflate your balloons.
Remember, guys, this is obviously, we're kind of talking through this and not, going to the time limit that we would be, aggressively managing this patient. These are I've said this before, these are the patients where you want to get extremely aggressive and start hammering these skills out. But remember to prep your equipment, okay? Use the resources on scene. Get somebody else to get in there, blow up the balloons, make sure you don't have a punctured balloon that's going to deflate while you have it in there. So just remember those little steps, okay? But again, we're kind of going through this so we can talk through this, okay, slowly.
Good point. So then we're back on here and, we've got good compliance. We know we're in the airway, in the esophagus, and then passively ventilating the airway. Okay? We'll get this out of the way just for visual purposes. All right, so we've controlled hemorrhage, we've maintained C-spine immobilization, we now have his airway, we're able to ventilate and oxygenate and ventilate the patient. So we're at a relative, definitely a relative stable point, right? We've controlled a few things. You're next going to go on to the rest of your assessment, assess his lung sounds, and are we hearing this, properly? Does he have diminished lung sounds? And we all have been through this, so we know he has rib fractures and a pneumothorax on the right side. We'll address that. This is probably the point where I would say I would put on some kind of better stabilization for a C-spine. So let's talk quickly about soft collars versus hard collars. So soft collars are meant, truly for somebody with a low mechanism of injury who has neck pain that you think is a very low suspicion for having a cervical spine fracture that could become unstable, right? You're not worried about a spinous process or a transverse process fracture. That's not what you maintain C-spine immobilization for. You maintain it for unstable spinous or unstable body fractures of the vertebrae that could move and slip and then impinge on the cord, making them quadriplegic for the rest of their life. And then you're basically doing all this work for nothing to keep them as a quadriplegic. So it's got to be high on your priority list here. Soft collar is not appropriate in this mechanism of injury. Massive rollover, MVCs, ejections, drunk patients, even if they're walking outside their vehicle after a horrible accident, probably need hard cervical spine immobilization. And you have to consider the elderly patients who fall, who have lots of comorbidities or metastatic bone cancer. They're going to fracture a lot easier. So think about high-risk patients and high mechanism injuries is where I want to see hard cervical collars. Okay? So if we've maintained the airway, we're probably at a point where we can stabilize this now. And I'll let you put that on and I'll continue to hold this.
So I should have measured it out, guys. I know that we're kind of going through this with the talk, but remember we go and check with our hand right here, okay, to the lower part of the jaw to the shoulder there, okay, and that's what we see the measurement of what size collar, and then this thing adjusts accordingly, okay. But just for educational talking through purposes, we just put it on right there with the rigid collar, okay.
Okay. So now we're on to breathing, right? So we've got his airway in. We'll assess his lung sounds. You know, I like anterior because one, you're going to hear, this is where pneumothorax air collects is in the most superior or most anterior part when they're lying supine. So I assess that, also listen laterally. And what we were told in your case is you've got decreased breath sounds kind of over here on this right side. So a couple ways to address this, right? So his blood pressure was 80s or 90s. His heart rate was in the 120s. I don't remember their oxygen sat, but I think that was 88, 92.
Low 80s, yeah.
So is it a tension pneumothorax at this point? It's hard to tell, right? So as their blood pressure gets worse, as you ventilate them and increase their intrathoracic pressure, you're going to see their blood pressure continue to drop. And why is that? So basically your intrathoracic pressure is going to continue to rise as you're blowing air into this pneumothorax space. That then in turn puts pressure on the right side of the heart, and the right side of the heart with pressure on it can't fill like it would normally do anymore. So you decrease your input, which decreases your output. So you get hypotensive tachycardia to try to compensate for that in this patient who has multiple other problems. So do you need to needle decompress him? If you're 2 minutes from the hospital, maybe there's other things that you're working on. If you're 10 minutes from the hospital, probably yes. Let's talk about needle decompression on this. So 2 places to go, right? So we've got your anterior approach or your lateral approach. Anterior approach is your mid-clavicle, so mid-clavicular line, and it's in the second intercostal space, which is just below the clavicle. Your lateral approach is in the fourth intercostal space, which in a man with normal chest tissue that doesn't have anything moving, it's nipple and it's straight down from there in the mid-axillary line, not the anterior and certainly not the posterior. So mid-axillary line, fourth intercostal space. In a woman, you take the inframammary fold, not where it's the most obvious down at the most inferior margin. It's at the higher end where basically that inframammary fold starts to fade is what you call fourth intercostal space. So don't take the low approach. Always follow that inframammary fold to where it kind of disappears, and then that's where you're going to do your needle decompression. Also the same spot where I do chest tubes, right? We talk about needle decompression. I want to show you a little bit of variety here. So we tend to just take this giant thing and shove it blindly, right? We shove directly into the second intercostal space, insert the whole thing, pull out the needle, and hope that we've obtained success. The way that I would advocate to do this, where you get some confirmation that you have actually gotten into the pleural space, is take your needle, hook a 10 cc syringe up to it. What happens now, so obviously air moves into this very easily. So when you get under the skin, when you do this, so you get under the skin, get this little bevel beneath the skin, then you start to pull suction. And right then there's tissue collapsing on this tube, so you can't pull suction. It'll kind of give you this air, plunger movement, but it's going to have resistance on it basically because it's all collapsed here on the bevel. So once you get under the skin, start to pull suction. And then as you advance this and you get into the pleura, you get this big whiff of air very quickly as you have suction on it. And it gives you confirmation that that's in place. Once you're there, let's say as I'm entering this space, I'm under the skin. I start to pull suction. As I advance, I get a big whiff of air right there. You stop advancing the needle. You disconnect the needle from the angiocath, and then you just advance the angiocath and not advancing the needle. So you minimize the trauma that you cause that you can't see. So once you're in and you get your puff of air, hold your catheter steady, disconnect your needle, and advance your catheter without advancing your needle, okay? So as we do that, let's say, pretend we're just in I like the lateral approach. I think that's probably a better place to do it. When you do it on the left side, you do not want to insert this needle blindly into everything, because you'll get lots of blood return and you'll be in a lot more trouble than when we started. So advocating certainly for this syringe-based approach. So my ribs are frozen, so we're going to go just out to the side of them, okay? So let's say this is the rib. I'm going to go on top of the rib to avoid that neurovascular bundle that exists on the inferior margin of the above rib. So I take the top of the rib, just go over the top, I get under the skin, full suction, and as I advance, find a puff of air. So now I know I'm in the pleural space. I can disconnect and then just advance my catheter without advancing my needle, okay? Just another way to do it that gives you a lot less complications than blind insertion of this enormous catheter.
So Doc, let me see that real quick. Some of you guys might have questions about this. So this doesn't actually screw on, guys. It doesn't have a little bevel, I guess, at the end there. I don't know what you call it, where it screws in. You got to kind of jam it in there, okay, so kind of keep it stable on there, okay? So just kind of keep that in mind with the technique that the doc is talking about. Just kind of jam that in there, and then you can this can screw off, and then you get that thing off, okay? You get that needle off, okay, and you leave the actual catheter in there.
Okay, then we're going to reassess, listen for breath sounds and vital signs, labs, get them on the monitor, and rapid transport. Okay, so that's that's probably in this scenario, given kind of how we described it, how I would personally manage it. It's not to say that is the only way or even the right way, but it's the way that I would tend to manage it and the things that I think about. Some other considerations. Let's go ahead and pull this out here. So other considerations, if you decide you want to, put a definitive airway in him and do an ET tube, it's a challenging airway, okay? So bloody airways with facial trauma and, who knows the instability of all these fractures here, you're going to have a face that wants to collapse. And sometimes you've got to pick up on their front teeth to be able to see them into their airway. The way I set up the way I tend to set up a ET tube, it comes out of the package like this, right? It's got the stylet already in place. So what I like to do is I straighten this whole thing out, undo this, the stylet, and I advance the stylet just to the very tip of the ET tube. So you don't want it past it, you just want it really to the end to give you the best control. And then what I do is, instead of curling this thing, which when you put it in the airway becomes an obstruction to your view of the vocal cords, is you just make a little kind of hockey stick on the very end. So that's really the angle at which that I like to intubate. So then when that passes, into the airway, this all drops out of the way, and the only thing that's kind of sticking up is your kind of the tip of your ET tube, rather than this curled huge thing and you're obstructing your view. So just the way that I tend to intubate. Guys who have a lot of experience will develop their own way as well. Okay.
And just to kind of add on that, Doc, one thing that you were talking about is you have this huge curvature on the blade, and you're talking about a bloody airway where you're gonna have just a little minute time to get it into that trachea. Okay, if the blood allows, obviously it's gonna be very challenging. But if you were to kind of maneuver this thing, you see the exaggerated movements on that tube. Right, it's going to be big, and you're going to need that limited time to get into that trachea. Okay, but if you have it nice and straight out, like the doc was talking about, the movements are a lot smaller. Okay, and not so dramatic. Okay, so just keep that in mind too. And it's a little easier to maneuver that ET tube when you're looking for that trachea.
Yeah. Good point. Okay, so what do I generally use? I like a Mac 3 or a Mac 4. In a large adult, probably a Mac 4. Smaller adult, a Mac 3. The Miller blades they're certainly an indication for these, but as you can see, they're a lot skinnier, and you definitely don't have much of a, your view becomes much smaller, especially in a bloody airway that collapses over this versus your wider, Mac blade. So the other consideration when you think about intubating a trauma patient with all of this and maintaining C-spine is you can't get the view that you want by all the manipulations we usually do, right? So your cricoid pressure is somewhat obstructed, so you'll play with that a little bit, but you can't. I always get the best view by being able to flex the patient's head backwards or extend the patient's head, and you can't do that in a trauma patient. So you are stuck with an inline stabilized airway you have to evaluate for. Sorry. So you sweep the tongue out of the way. You got to keep the head in C-spine and trying to look in here on the ground. Like I can't see anything, right? So if I did that, I would probably just throw this to the side. So there's too much blood. Even if I've got suction trying to get in here, and I can't see anything. I'm out. I'm done. So I wouldn't. This is not an airway I would play with for a long time. If I made the decision to do that and I came into this, I would just take it out of the way and I'd go get the king airway. If I was able to see well, might be a different story. One of the questions that was brought up with this is it better to intubate them in case there is a lower airway bleed that you need to get an ET tube in to put some pressure on to help alleviate some of the bleeding? I don't think that's pertinent in this case, to be honest with you. I think all of his trauma was here, and the mechanism of injury wouldn't create any kind of tracheal laceration or hemorrhage into his airway below that. If it did, it would be exceptionally rare, I would say.
Doc, we kind of talked about really giving an evaluation and looking at your patient, right? If you're seeing this much facial trauma, likely your injuries are going to be sustained right here versus if you're seeing neck trauma, then you might see underlying bleeding or something in the trachea.
Exactly. Or, the gunshot wound to the neck or something that there's bubbling coming out of it. Maybe then that's an indication. But I would say for blunt trauma, you're not really considering hemorrhage, lower down in the airway. The other consideration in managing his airway was to use the, video laryngoscopy. Problem with video, it's fantastic to kind of get you around that corner so you can see the vocal cords easier. Bloody, mucousy, vomiting patient, any of that, becomes completely obstructed very fast. So I really like these and I like video laryngoscopy, but liquid-filled airway, you're going to have a lot of difficulty seeing anything that you want to see.
And one thing, Doc, that just to kind of bring up with this too, if for whatever reason you don't have the manual, whatever you want to call old school techniques, okay, some of the guys are kind of throwing those terms out there. This can be used as a manual. I don't know if that can, but it has the curvature on there, okay? So just keep that in mind. It's another tool in the toolbox. Okay, I don't know if it would work for you. Like the doc said, keep it in mind. If you start getting bloody, it's going to probably obstruct the camera. A lot of guys we were kind of observing them as they were going in with the eye view, but just something to keep in mind, okay, to make your best judgment on the scene.
Absolutely. And it is very similar to the Mac. It's a Mac 4 basically. So it can operate as just a direct laryngoscopy as well. And then really the only other, so let's go on to then, if we control the hemorrhage, we maintain his C-spine, we maintain his airway, we can oxygenate, we can ventilate, needle decompression for his tension pneumothorax, and then move on from there, right? We've got somebody doing IVs. We talk about IV fluids using blood tubing because we know with the amount of blood that we saw there that he's probably going to need blood. So putting that saves a step when he gets to the hospital, makes it a little faster to give him blood. How much fluid do you give him? There's certainly room to have what we call permissive hypotension in a trauma patient, right? So this isn't a patient in septic shock. This isn't a patient who has got that we know of some massive MI, unless that's the reason that he fell off the scaffolding in the first place. But in trauma, you assume trauma and hypovolemia is the reason that they're hypotensive. But you don't want to overcompensate that by making the patient coagulopathic by giving them too much IV fluids, right? So 4 liters of IV fluid in this guy creates Kool-Aid, and this bleeding never stops, and whatever bleeding is coming from his facial fractures never stops. So I would advocate that if his blood pressure is 80s to 90s, that maybe you don't flood him with fluid, that you give him a liter en route to keep your IV tubing open, give you a little support, but I wouldn't hang 4 liters of fluid on this guy unless he's crashing, right? His pressure's 50, you're gonna do whatever you have to and give him as much fluid, and then I'll correct that with blood and FFP and crystalloid stuff in the hospital. But don't be afraid of having somewhat of a lower blood pressure in a trauma patient who's bleeding, because we will slowly correct that with blood products, not just with IV fluids. And then transport-wise, so where are we going to take this guy in the first place? So with as much of a mess as this was, this is a horrible case to put in the back of a helicopter, just like he's your horrible patient in the back of an ambulance, right? Limited space, limited resources. I like this patient to be brought to the hospital. So if you're here in Los Alamos, if you're in White Rock and it's a 10-minute ETA for a helicopter, it's going to be a judgment call. But I mean, this is a lot to deal with in the back of the helicopter, trying to rapidly transport them. And if they show up dead to the hospital, we didn't do them any favors. So taking them to, or by air medical transport, if we take them to the hospital here, let us stabilize them, take the needle decompression, convert it to a chest tube to have less complications, take the airway and assess whether we want to change that from your King airway into a definitive endotracheal tube. I think the appropriate place, and I won't fault you if you do something different, but the appropriate place in my mind for this patient would be the closest facility that you can get him to the fastest, here being Los Alamos Hospital. The other patient, the extravasation that we had, or the evisceration that we had, he's pretty stable. He could go either place depending upon your resources. And I won't get a lot into that because that's not what I do. I don't work in the field like you guys. So that's your judgment call with your captains and your chiefs.
So, Dr. Hammond and I have had this discussion. Chief Bartlett has been in these discussions. We all know it's a regional standard. That's kind of what we have here, because we're rural EMS, so we fly a lot of patients out. I think Dr. Hammond brings a pretty good justification as to why to go to the hospital. But at the end of the day, if you do have this patient and you're way out there in White Rock, that's again going to go back to your judgment call about anticipating how much time it's going to take for the chopper to get there, right? That's kind of the captain's, that's on the captain's mind, is kind of getting all these time limits along with the medic, working together on that. If the chopper can get there with the amount of time and this patient's going to be stable, well then maybe that might be a good option, or it may be a better option to go to LAMC with, okay? You're way out in District 5. That's another situation where you might need a helicopter, that kind of resource. So, but anywhere in town, I think we're likely we can't justify, waiting for a helicopter on that. So just kind of keep that in mind with your operational kind of internal time clock of when your chopper's going to get there versus how long it's going to take your ambulance to get to the hospital. That's another kind of thought that comes up, Doc. What about scene time? What's your recommendation for scene time?
This type of patient you don't want to play with too long, right? So this is a complicated patient with multiple reasons for things to go bad, right? He's bleeding, he's hypotensive, he's got a pneumothorax. That needle decompression isn't going to last you forever, right? It's going to occlude, or something's going to go wrong with that, and you're going to have to do it again. So the complications are much higher the longer that you're on scene. So I would say, you want rapid transport, but you want to be able to stabilize it enough first. Could you do all this in the back of the ambulance? Probably. And I think it depends on this patient and how well this airway is open. Are you able to open the airway and suction and ventilate him easier with just bagging? Then maybe you work on the airway in the ambulance, or the needle decompression in the ambulance. So I think scenario, we didn't delineate where all that had to be done, but that's something to consider, is what can you get done on scene versus what can you do in the ambulance en route to the hospital.
Dr. Hammond brought up various skills, right? He brought up the King airway. All providers can give an OPA and manage that with assisted ventilations. Then he brought up an innovation. So one of the thoughts that one of the points that kept getting thrown out there during the drill is to free up a medic on this stuff, right? So that's when we really think to work as a team, right? The paramedic is the individual that is the airway expert, right? They go to extra training, extra education. They have an extra skill set with that, being an innovation. So basics, get on that, use it as your opportunity to get on there and free them up, right? You're the one that's going to control the bleeding. You're the one that's likely going to hold the manual stabilization. And that could, if you guys work as a team like that, that could quicken the time on scene, right? That could allow the paramedic to get on there, decide what airway intervention he wants to do or she wants to do, okay, to manage this patient's airway.
Yeah, I like it. So I think that probably wraps it up. If there's other questions or concerns or things that we've left out or other topics that come up, let us know. We'd be happy to address them in an email or another format like this. But thanks for paying attention and listening to us go through this.
If you guys got any follow-up questions, just feel free to email me and I'll get them over to Dr. Hammond and then he will answer them. Like we've said, on the next medical director training. So I'd also like to know your guys' feedback on videos like this. We kind of our first video put together. I apologize about the stuttering and kind of going the little pauses we've had. We're trying to get it down and nail it down. So get in touch with us. We love your guys' feedback. Other than that, be safe, guys. Good luck.